Dr. Annamaria Iagnocco. She is a professor of rheumatology and director of the Academic Rheumatology Center, University of Turin, Italy. And she is the current president of EULAR. And incidentally, she is attending at this moment another IRA meeting, that's Italy Rheumatology Association meeting. So we're happy to have her here. Her topic is imaging of organ involvement in connective tissue disease. Over to her presentation.
Well, good afternoon, and thank you very much for this invitation in the Iracon conference. The role today for me is to discuss the imaging applications in connective tissue diseases organ involvement. I have no relevant disclosures to this talk. This slide shows the development of different imaging modalities in the years, and puts in evidence the technological advances that have led now to the use of very sophisticated imaging tools. But what is of value too is the applications of standardized techniques and also standardized definitions of pathologies. Tested by using different modalities and also many relevant new tools. For in the interest of time, we will not focus on the different manifestations that involve the musculoskeletal system and that can be evaluated by imaging modalities. On the opposite, we will focus on evaluation of organ involvement in those pathologies. And starting with the lung and connective tissue diseases, we know that any part of the lung can be characteristic of rheumatoid arthritis and of scleroderma as well, while non-specific interstitial pneumonia can be found particularly in scleroderma, but also in polymyositis or dermatomyositis, and we see the different involvement that can be detected in the different diseases as clearly shown in the slide. High-resolution CT, but also the functional tests and the steroid markers are usually applied for evaluating the extent and the severity of the alternative imaging options in this assessment. You see in this slide some cases, clinical cases of patients with different lung involvement. The first on the left is a rheumatoid arthritis patient, and the typical non-specific interstitial pneumonia pattern is shown with mild traction bronchiectasis and auricular shadow in both lower lobes. In the second patient that you see, in the second image that you see, this comes from a patient with rheumatoid arthritis and usually interstitial pneumonia, where traction bronchiectasis are shown by CT scan and also honeycombing in both lower lobes. CT scans show reticular shadows in the peribronchial area and patchy shadows in both lower lobes. But the most evident abnormalities can be detected also in systemic sclerosis. On the left, interstitial pneumonia. But we can apply also novel imaging modalities for assessing lung pathology in systemic sclerosis. And we have different modalities that have been used, being the CT scan, including high-resolution CT, the standard of care for the assessment of interstitial lung disease. But we also have new applications with MR and ultrasound that can have the advantage of being of not having radiation exposure, but also showing different pathological manifestations. This is an interesting study we recently tests were used for evaluating the different involvement. And the quantitative analysis of chest scan by the densitometry was able to quantify the extent of interstitial lung disease in systemic sclerosis. Therefore, being a quantitative analysis, it mitigated the subjectivity of the semi-quantitative analysis based on visual scores. And the extensive pulmonary involvement in those patients was associated with pulmonary and functional impairment. An interstitial in patients with systemic sclerosis is clearly demonstrated in the upper part of the panel, showing a predominance of ground glass and reticular consolidation and a diffuse involvement related to non-specific interstitial pneumonia. In this case, in this patient, in this graph, you can also know clearly see the different involvement in different groups of patients. Sclerosis versus non-interstitial lung disease, but also between diffuse interstitial lung disease and no interstitial lung diseases, as well as diffuse and limited form, respectively. And this was present in the different thirds of the lung that were evaluated, the basal, the middle, and the apical third. And the analysis of the involvement at different erosion depths showed again that the extensive interstitial lung disease was clearly having abnormalities that were statistically significant compared to patients with limited interstitial lung disease or no interstitial lung disease, and the continuous graph on the right clearly showed the same abnormalities. This is another study in which FDG PET was used in systemic sclerosis. And this study demonstrated that in patients with interstitial lung disease, there was an abnormal interstitial lung pattern of FDG uptake. And when the patients were compared more clearly and diffuse evident abnormalities compared to those who are not interstitial lung disease. In this study, you see that those patients who had the follow-up of progression of the interstitial lung disease had advised at baseline an increased uptake compared to those who didn't demonstrate a progression, a follow-up. This is another interesting set of images showing a few Denmark color overlap images with was also evident in those areas of the lung that appeared normal at normal CT scan. This is another study, again evaluating the use of FDG PET CT scan in patients with or without interstitial lung disease, again systemic sclerosis patients, and an increased uptake was evident in those patients who had interstitial lung disease. In this study that was also recently published, nearly 400 patients with systemic sclerosis were evaluated for the detection and the assessment of V lines detected by ultrasound. In this study, there was a prognostic value of the presence of those V lines, and particularly when the number of V lines was more than 5, this was associated with the new development or worsening of interstitial lung disease, and also the survival. The event-free survival curve shows that in patients with more than 5 V lines, there was an increased number of events. What about the use of ultrasound in the assessment of the skin in systemic sclerosis? We recently published the recommendations for the execution and reporting of sinus ultrasound in those patients. But this was preceded by the publications of a systematic literature review which informed those recommendations. And the studies that were evaluated were mostly focused on the B-mode and elastographic assessment of the skin, and different techniques were applied, and globally the studies that are currently available in the literature show good inter-intermediate reliability, and particularly also a few studies evaluated the responsiveness to change. So ultrasound has the potential to become a reference tool to assess the involvement of the skin in systemic sclerosis, but there is a heterogeneity in different studies, and there is a need for standardization, and this is why the recommendations were published. But now we move to another aspect, that is the application of imaging in the assessment of the neurological involvement in patients with sleep. We know that the neuropsychiatric sleep comprises a number of different syndromes that can affect the central and the peripheral nervous system. And conventional neuroimaging is representing by pathologies and different involvement in a very non-invasive way. MR is the technique of choice for evaluating the involvement of the neural involvement in patients with sleep. But we have different techniques that have been used, and the neuropsychiatric active sleep was evaluated with the application of neuroimaging technique that shows the different sensitivity and specificity. And MR is able to show and detect structural brain abnormalities in neuropsychiatric sleep, because it has excellent soft tissue contrast, it has the ability to acquire multi-planar images, but also clear because there is a poor correlation between structural anatomic changes and clinical neuropsychiatric manifestations and structural anomalies can be detected both in patients with and without manifestations of the central nervous system. We have different conventional neuroimaging applications that show the abnormalities, and they want to distinguish white matters from gray matter diseases. It also measures cerebral atrophy. And the most frequent MR patterns are small fructate, other intense focal lesions in subcortical and periventricular white matter and cortical atrophy. Both clinical and structural abnormalities of conventional neuroimaging. So advanced neuroimaging has been applied, and it can be used when we have a normal conventional MR, but there is a lack of explanation for the signs and symptoms that are present in the patient. They appear, these advanced MR techniques, to show promising results, but they still have no clear applications in all cases, and they are not completely. This is a clinical case of a patient with glee and cerebral vasculitis, and you see different patchy areas of hyperintensity that are shown in different areas. And this is another case of a patient with acute infarction, DUI lesions, and DUI shows different hyperintensity lesions and restrictions in both basal ganglia, and this is a patient with glee and antiphospholipid syndrome. Another interesting application of neuroimaging of multiple sclerosis. And this is a study that was evaluating white matter lesions in patients with glee compared to healthy individuals, and although the presence of this manifestation was significantly larger in glee patients, there was no significant difference that were present that could be detected between different glee subgroups with or without a neuropsychiatric manifestation. This is another study in patients with lupus and without neuropsychiatric manifestation, applying FTG PET and diffusion cancer MR. And you can note here that fewer to control, and also you see that there were different abnormalities in different areas of the brain, and as you can see in the different images, and the metabolism in this region was significantly higher in glee patients compared to healthy controls, but there were no statistically significant difference between the different subgroups of glee patients. This is another study that was recently published that was aiming at identifying the associations between the autoantibodies and the structural lesions, including white matter lesions and different abnormalities in patients with active neuropsychiatric glee. Well, no. Associated with ischemic lesions and cerebral atrophy. What about the use of imaging for muscle inflammatory myopathies? MR is the reference standard for evaluating inflammatory myopathies, and it is able to show in a very sensitive way and non-invasive way different abnormalities that can be present at muscular level in those patients. Particularly the muscle edema pattern and fat infiltrations are the manifestations of myopathy, and the distribution of and patterns of muscle involvement might suggest a specific disease. So polymyositis and dermatomyositis show different muscular and involvement with asymmetric pattern in different areas, and there are macroscopic differences between dermatomyositis and polymyositis. Dermatomyositis and patchy muscle edema, and also higher subcutaneous tissue edemas that typically mirrors the distribution of the skin involvement, while polymyositis has more diffuse muscular edema and the absence of subcutaneous involvement. And these are cases of patients with polymyositis. You see in this case the extensive after 6 months after the treatment. And this is another case of a whole body MR in a child with polymyositis, and there was a diffuse edema pattern in different muscles. And in this case of, again, a young girl with dermatomyositis, it was possible to show the fluid collection related to the milk of calcium deposit in the intermuscular septa with local calcifications on X-ray. This is another study that was recently published in dermatomyositis and polymyositis with whole body MR showing variety of fatty infiltrations at different levels in the muscles in polymyositis. Opportunity to detect also associated pathology. What can we say about the salivary gland in Sjogren's syndrome? Well, we have the possibility to apply and to use different imaging modalities. Salivary gland biopsies is mostly used for diagnosis, but also particularly for the diagnosis of associated lymphoma. Ultrasound has been shown to be helpful in for the diagnosis of primary disease, Sjogren's disease, and also we can use FDG PET for the evaluation of Sjogren's disease associated with lymphoma. You see in these stylographies of the parotid glands the two-dimensional and two-dimensional evaluation of the ductal This was even more intense in patients who had, in addition, parotid gland lymphoma. This is a case of PET-CT scan and MR in patients with Sjogren's syndrome, and you see that those who had lymphoma had a pathological uptake in the parotid glands and also in the tonsils, and the MR sequences shows this different uptake. And this is the result of the examinations that were repeated after treatment with no pathological uptake in the parotid. Sjogren's syndrome, and you see that different studies in this systematic review and meta-analysis have been applied for evaluating the sensitivity and specificity of ultrasound compared to the diagnostic criteria for the diagnosis of primary Sjogren. And what we can see here that the full sensitivity and specificity were 80% and 90% respectively, with a narrow confidence interval. And you see here that independently of the different scoring systems that were used, the high sensitivity and specificity of ultrasound is very relevant in the application, in the analysis of the salivary gland involvement. So in conclusion, of patients with different connective tissue diseases. And thank you very much for your attention.
Thank you, Professor Annamaria, for this beautiful about the current status and their limitations. And thank you very much for attending and contributing to our meeting, and despite being in another IRA. And is there any questions from the audience or one or two comments? If there are none, do you have anything to say to us, Professor Annamaria?
Yes, I'm so sorry that I cannot be with you. I would have been delighted. But you know, exactly in these days, as you mentioned before, we have the Congress of the Italian Society for Rheumatology, so I have some institutional commitments here. I cannot fly to another country, unfortunately. But as I mentioned also, I would have been delighted to be with you. And thank you so much for inviting me. I hope that you found my lecture helpful or interesting.
It was very interesting. Thank you very much.
Thank you.